Okay. Mita sent out this wonderful set of ABGs. We start with the first one. A 65-year-old very obese female with diabetes, hypertension, and breathlessness since long time is admitted with increased cough for 4 days, drowsiness for 1 day, and the blood gas is done soon after admission. Comment on this ABG, worth 19 marks, and give 3 reasons for the high PCO2. All right. Now, I want you to enter here in the chat what each one of you, what did you write? What was your interpretation here?
Yeah, so you don't have to work out now. What you have your answers with you, right? So just write down what was your answer of first question. Comment on the ABG.
So, what was the or you could raise your hand if you like, and I don't know which way you want to do it. Best is to everyone participate. Smita, yes.
So my interpretation to this ABG was hypoxemia, AA gradient is increased, hence lung pathology. There is hypoventilation.
But when you say hypoxemia, it's correct. It's hypoxemia. You also need to grade it: mild, moderate,
moderate, severe.
So it is mild hypoxemia.
Yes, it's mild hypoxemia.
Right.
Yes.
A gradient was high.
Increase, hence lung pathology. There is a hypoventilation. So
coming to still talking about lung pathology. What type of lung pathology are you really thinking about?
It can be consolidation.
Okay, what else?
And if I saw PCO2, if I consider hypoventilation, then it is a COPD with infective exacerbation.
It is possible. What else?
Patient
basically, what I wanted to stress is, in the history, when it is written breathlessness from a long time, okay, your consolidation cannot be the only thing. So there is a chronic nature to this. Breathlessness since long time. And now there is a component which is there for 4 days, that she has deteriorated in 4 days. Okay, so there has to be a chronic lung pathology and an acute lung pathology. Have you understood from the history that breathlessness for a long time and then increased cough and drowsiness for 1 day? So that's what I just wanted to say.
So on the background of COPD, patient is having some other respiratory infection.
No, see, I wouldn't at this stage commit.
ILD.
I will just say, yes, it could have been interstitial lung disease. It could have been emphysema. It could have some chronic lung problem was there. And now the acute part, yes, you can say could be infection, could be heart failure, could be embolism, could be whatever. So there is a chronic and an acute component. That's all you can say at this stage. Okay. Then you see the PCO2 is high, so patient is
Sir, 1 second. Sir, 1 second. Sir, have you started the recording?
Yes.
Okay.
I think I have.
Yes, sir. There was notification that showed this meeting is recorded.
Yeah, recording is going on. Yeah.
Sir.
So that's all that you can say. But don't forget that there is a chronic component from the history, breathlessness since a long time. Okay. Otherwise, you tend to look at an acute component. You said hypoventilation. Now go on, Smita.
Primary respiratory acidosis.
Yes, very good.
We don't mention about compensation, but I have written appropriate metabolic compensation.
Why do you say that?
Because sir, PCO2 is high by around 70, and bicarb is also high, 34. So,
so how do you know it's appropriate or not?
About 1.5 to 1 increase in bicarb, increase in PCO2. Every increase in PCO2 by 10, so there is an increase in bicarb
by 1
to 1.5 times.
Yeah. Okay. So really, it's just by 1, but it's not 1.5. So 1. So by 7, you would have got so 7 more, 24 plus 7, 31. You would have got. Okay, and it's a little more than 31. So that you need to think about as a possibility. Okay, then,
Then
or you could say that it's just
symptomatic-
3 more, not very significant, and I just think there's a appropriate compensation. Okay, so there's an acute respiratory acidosis.
So the likely coming to the etiology part, so it can be likely because of, as I mentioned, COPD with consolidation, or it can be obesity, hypoventilation.
No, but see now, this is where there's an internal inconsistency. You have said this is an acute based on your compensation, right? But then
Right.
when you say COPD, that's not an acute component at all. So either you are saying that it is COPD who is a non-CO2 retainer, and so this is totally acute, because the moment you say COPD, there has to be a chronic hypercarbia also. Okay, there are two types, with rise in PCO2, without rise in PCO2. So you have to postulate that as one possibility. Anything else?
Sir, for rising PCO2, there can be cause, central cause for hypoventilation, like any sedation or
Okay.
any chronic use of cough suppressant like codeine.
Yeah, exactly. I mean, when you say cough for 4 days and drowsiness, you have to consider that some cough syrup or antitussive, which are sedating, could have
No
contributed.
voice. No voice.
He's there.
Voice.
We can hear. There is some
We can
problem
hear.
from your side.
Yeah, we can all hear. So, okay, now anyone wants to add something to this?
Sir, one more thing, raised PCO2 can be because of poor lung compliance or poor chest wall compliance, like obesity, I mentioned.
Okay,
Sir,
There can be central cause.
sir,
okay,
Lalit here. Can I,
Yeah, Iqbal.
yeah.
sir, it is acute and chronic respiratory acidosis.
Your voice
Why
is
do you
Because
say
breaking.
that?
compensation.
Your voice is breaking.
He said acute on chronic
Sorry?
respiratory acidosis. Your voice is breaking. There's some issue from your side.
Sir, it is acute and chronic respiratory acidosis because it is outside the compensation range. Bicarb is outside the compensation range. It must be the chronically compensated, and acute even disturbed this presentation.
No,
No,
so
so
she
if
could
it
say
was
acute
chronic,
respiratory acidosis with metabolic alkalosis. If it is out of compensation, I would say added component of metabolic alkalosis. Why acute on chronic? I think so we can start with the discussion of the case.
okay, anyone has anything else to contribute?
Sir, as it is said that it is hypoventilation, can't it be an OSA component adding to it?
You already
Okay,
said
that's
that.
one possibility. Okay.
Because obese patient with breathlessness
Yes.
from longer times.
So, obese hypoventilation syndrome, yes, you can postulate
Yes.
that. You can postulate central sleep apnea. You can do that. So, but you know what? Why I don't agree with this as explaining it, and let me try to explain it to you. Let's see.
Sir, morbid obesity may be an interstitial lung disease and COPD may
Yeah, but
be
doesn't
type.
explain the whole thing. That Rakesh is in part one exam you can get away with this, but in part two exam the FCCN and in real life you will not get away with this. So let's try to see what is the problem. Why am I not getting control?
Sir, it's coming.
Okay.
It went to the next slide. So
Okay. Yeah.
it's going.
So first, look at absolute value. What Smita said, absolutely right. There's mild hypoxemia. The expected PO2 would be 225. It is less than that, so you have to calculate alveolar arterial gradient. Smita calculated the alveolar arterial gradient. It's around 120, 121. So there is a lung pathology. You cannot really comment more on this, but the history tells you there's a baseline chronic lung disease. It could be interstitial fibrosis, it could be COPD, it could be anything. And on top of that, there's an acute insult. why always think of infective exacerbation? It could also be heart failure. It could be pulmonary edema, pulmonary, anything could be there. That's all that you can make out from here. The second thing is ventilatory status correctly. There's no doubt about it. There's hypoventilation. The interesting part is the acid-base status. There is an acidemia, no doubt. Okay, the PCO2 is raised, which explains the acidemia. So there is definitely a respiratory acidosis. The bicarbonate does not explain it. It's on the alkaline side. So this is a primary respiratory acidosis. Now, what about compensation? So if it's a respiratory acidosis, you have to think about acute or chronic. The fact that the pH is not normal, there has to be an acute component. Okay. Whether there is an associated chronic or not is a separate thing. But the moment pH is not normal, there is an acute component. So if you were to calculate for acute respiratory acidosis, as Smita said, the PCO2 has increased from 40 to 110, that is 70. Okay, you add 7 to 24, you get 31. Okay, that is understandable. What about the extra 3 that is there? Now, so one possibility is there's an acute respiratory acidosis with metabolic alkalosis. One possibility, okay, primary scanning of, but it doesn't explain the whole picture. So look at the pH for given PCO2. Sorry, something in my throat. Now, you know that, let's look at this. Whenever the PCO2 rises, the pH changes. So look at what the pH is for the PCO2. Now, we know that the PCO2 is increased by 70. If it was an acute change in the PCO2 by 70, we know that for an acute change in PCO2 by 10, the pH falls by 0.08. It's 0.07 written here. Some people say 0.07, but majority say 0.08. And if it is chronic, it changes by 0.03. Now, in this patient, since it's increased by 70, if it is acute, what would be the pH? It would fall 7 times 0.08. So the pH should have been 6.84. Is it 6.84? No. If it was chronic, it would be 0.3 into 7, that is 0.21, 7.40 minus 0.21, so 7.19. Now look at 6.84 and 7.19 and what the actual is. So what do you think is the predominant component? Is it acute component predominant or is it a chronic which is predominant? Here, it looks like it's a predominantly a chronic component. We'll see how much. And the acute component is not that much. So the major component is chronic. So, and since it doesn't fit in with either of them.
You're stuck, sir.
My voice is not coming?
No, now it is coming. It was stuck.
Okay. Sorry. So what I said is by looking at if it was acute, the pH should have been 6.84. If it is chronic, it should be 7.19. It is 7.10, so it is in between them. And therefore, there is an acute on chronic respiratory acidosis. What would be the baseline PCO2 before the acute component? So here we are learning how to differentiate the chronic component from the acute component. Now, you know that if it was a chronic compensation, then the pH would be near normal. And normal pH is 7.35 to 7.45. So at least 7.35 is the lowest. You need to calculate what would be the PCO2 for 7.35. Now, so you have to work in reverse order. pH should be 7.35, right? So you know that for every 10 increase in the PCO2, pH decreases by 0.08. So let us work backwards. Let's start with 7.35 and reduce by 0.08. We get a pH of 7.27. At this time, the PCO2 would from 110 would be 100.
Vinod, mute yourself. Vinod, mute yourself.
Now let's go further from 7.27 because there are pH is 7.1.
We have to reach 7.10. Yeah,
So
we have
you
to
again
reach.
subtract 0.28, so you get 7.19. Now, and you decrease the PCO2 by 10. Same way, you again do that. And when you do that the third time, you get a pH of 7.11, which is close to 7.10, and the PCO2 is 80. So here you say that, okay, the actual pH is 7.1. So the baseline PCO2 before the infection, before the pneumonia, before the heart failure would be 80. So how much is now the chronic PCO2 was 80. So what is the acute rise? It is 110 right now. It was 80 to begin with chronically. So it is only increased by 30. Okay. Have you understood? Now, please tell me, all of you have understood, because the next step is very important. So can you please tell me?
This is also important when you put the patient on the ventilator, because if this patient has to go on the ventilator, you will have to target the pH as 7. I mean, you will have to know
PCO2 as 80.
PCO2 should come down to 80 for normal, that pH of 7.35. You cannot ventilate the patient to target the pH of 7.4. Patient will never come out of the ventilator.
Okay, so now quickly tell me you followed so far, because the next step is very important.
Yes. If anyone is not understood, no one is going to explain to you this again.
Okay.
Okay,
so
most of them have
majority of
understood.
them are saying that.
That's great.
Fine. Now, having reached this step, what have we determined? That this patient, before he felt acutely ill, okay, for a long time he was breathless, his PCO2 used to be 80, and now it has increased to by 30 to 110. Now let us look at what the bicarbonate should have behaved. Now, the PCO2 chronically rose from 40 to 80, right? So what would have happened to the bicarbonate? For every 10 increase in the PCO2, the bicarbonate chronically increases by 3.5. So it has increased from 40 to 80, so 4 times. And therefore, the expected bicarb would be 38. So this person was moving around, chronically breathless, PCO2 of 80, bicarbonate should have been 38. Now, on top of that, he got an acute rise from 80 to 110. That is a rise of 30. And when there's an acute rise of PCO2 by 30, the bicarbonate increases by 3. For every 10, it is 1.
1.
So now the bicarbonate should have been the chronic component 38, on top of which the 3 also would be there. So the bicarbonate should have been 41. How much is it? 34. So why is it 34? Not that there is a metabolic alkalosis. Actually, it should have been 41, and it has fallen because of an acidosis. This patient has a hidden metabolic acidosis. Okay. Now, it seems surprising, but I actually went online and verified it with a few experts from outside. And they also agreed that if it is a chronic process there, then the only explanation is a hidden metabolic acidosis. All right. Now, so have you understood how we picked up this metabolic acidosis? Where's my chat? Now, can you please
Have you understood?
tell me if you've understood why there is a metabolic acidosis?
Only 2 people have understood, Sudhir and Adit. No, sir, Hardik is
If you
not
haven't
understood.
understood, we can explain it again.
Yeah.
So please explain it again, sir.
So that's it. What is the session for? If you were experts, you would need the class. The fact that you're studying for an exam means it is okay not to know it. Okay. So let us see if I can get a pen. Okay. Now we know that this patient baseline PCO2 was 80 and acutely it has increased to by 30 more to become 110. Have you understood this much? So
Yes, sir.
Yes, sir.
PCO2 chronically had increased to 80. What would have happened to the bicarbonate?
that also should increase.
So what is the chronic compensation? It would be 24 plus how much? From 40
For
it
every
has
10
become
rise,
80.
yeah, for every 10 rise, it increases by 3.5. Here it is increased 4 times, na, from 40 to 80. 10, 10, 10, 10.
So
So
plus
3.4
4
Yeah.
into 3.5.
No, 3.5 into, so it's 14.
Okay, is equal to
38 now.
38. Have you understood this?
So for his baseline PCO2 of 80, the baseline bicarbonate would be 38. Have you understood this much?
Yes.
So
Great.
this man was merrily going around. He was this lady was chronically breathless. Her PCO2 was 80. Her bicarbonate was 38. And she didn't come to the hospital at that time. She has come for an acute exacerbation. So what is that acute exacerbation? Now the bicarbonate from 80 has gone to
PCO2.
110.
PCO2
Sorry,
from
PCO2. 80 has gone to 110.
that is
That is, it
acute
has
rise of
increased
30.
by 30. Now for every 10,
Acute rise. How much? Let him, sir.
bicarbonate increases by 1.
You remember this? For acute respiratory acidosis, for acute rise in PCO2 by 10, the bicarbonate will increase by 1, 1, 2, 3.5, and 5, that table. So for acute respiratory acidosis, every increase in 10, it will increase by 1.
Remember that table that was there, na? 1, 2,
Yes, sir.
3, 4, and then we
And
said
we
not
said
3,
3.5.
it is 3.5, and
Not
not
4,
4,
it's
it
5.
is 5. Remember this table which we discussed in the orientation?
Yes,
If you
sir.
didn't attend the orientation, please listen to the ABG online which we have opened up. Otherwise, you will not understand these things. So by this logic, it would have increased by 1 for every 10. It has increased to 30, so it will be 3 more. Right? So 38 plus 3 becomes
41.
41. So this person should have had a bicarbonate of 41, but it is only
34.
34. That means it has.
It is less than what is
When
expected.
the bicarbonate falls, what is the process? Metabolic acidosis. Okay. And so this patient has a metabolic acidosis. Why do you think the electrolytes are given to you? Is there an anion gap or not? Okay, so if there's a metabolic acidosis, is this high anion gap or normal anion gap type? 139
It's a
minus.
normal anion gap. Normal
It's a
anion.
normal anion gap metabolic acidosis.
Hmm.
Okay. So your complete interpretation then becomes, it will be here, but from acid-base point of view will be acute on chronic respiratory acidosis with hidden metabolic acidosis, normal anion gap type. Okay.
Next.
What are the 3 reasons that could be there? Yeah, okay. I don't know how we can do that.
You go on that only, the pen cutting, and delete. Because otherwise this will come on all the slides.
Gita, even you can do it because I made you see.
It doesn't allow, it just says post only.
It doesn't allow. Anyways.
But sir, this will come on all the slides.
I
Go to
will share it
whiteboards. Yeah. Okay.
I will just share it again. Okay.
Okay. So let us just finish this.
The 3 reasons could be acute exacerbation of COPD. And as Meeta rightly said, someone said it could be obesity related hypoventilation syndrome. Okay. It could be the acute component could be, infection, could be heart failure, or could be sedative effect of cough suppressants that could be given. Okay. High FiO2
Someone given oxygen
could
on
also be a
admission.
possibility. Yes.
Hmm.
Because for 110 PCO2, the PO2 would have been much lower. And therefore, that's a possibility. 45% oxygen is going.
Mhm.
Okay. So,
So you'll
for the
have to
second,
reshare it.
yeah, I'll just reshare it. Just 1 second.
So all of you have understood this ABG. It was one of the difficult ABGs, but this is a real life thing.
Ma'am, one question.
Yes.
Yeah.
Bolo?
So, ma'am, if like as we understood that this is a chronic CO2, so in this ABG, should we write hypoventilation if the PCO2 might be given 70?
Hypoventilation is equal to ventilator status is independent of your
Okay.
acid-base status. So if
Okay,
you have to
ma'am.
comment on oxygenation, ventilation, and acid-base status, ventilation is just pure PCO2 value.
Okay, ma'am.
But in real life, this is the decision you take. And why is this important? Is the basic principle of ventilating a COPD is that you will ventilate to the PCO2 the patient is used to, or a normal pH. Okay. And if you ventilate this person and you ABG shows the PCO2 of 60, you're hyperventilating this patient. You should target 80 because that is the baseline that you have determined.
So ventilating COPD patient, you should never look at PCO2. You should always look at pH. You need to get the pH to near normal in these patients. So never look at just pehle jaiye, one slide before. Okay. So
Do you
whenever
have
you are
control, Mita? Do you have control?
No, sir, I don't have.
1 second. Slide control.
So whenever these patients you put on the ventilator, you should never look at the PCO2 COPDs. Always target near normal pH. Because if you try to target normal PCO2, like if you in this patient, if you target PCO2 of 40, patient will never come out of the ventilator because you are actually creating alkalosis for that patient.
You should have control now. It says you have control.
Okay.
Yes, ma'am. This thing is observed in many patients. Even they are okay
Yes.
with 50, and we are targeting. We should not target.
Yeah, we should never look at the pH. I mean PCO2. You should never
PCO2, yes.
always
It's
look at
normal
pH.
for them.
And
Also, that
oxygenation,
is why-
always look at the someone's and for oxygenation, never look at the SpO2. Look at patient's mental status. Okay.
Yes, ma'am.
But that is
Some
Got
we
it.
have had
why-
patients whose saturations are 38 and 40 and they are better off. The moment you give them oxygen to target that normal SpO2, they retain the PCO2, their oxygenation drive is gone, hypoxic drive, and then they worsen. So in COPD patients or CO2 retainers, look at pH and the mental status, not at PCO2 or PO2.
How many of you have heard this saying, COPD patients are difficult to wean?
Yes, ma'am. Yes, sir. They are
It's
like
rubbish. It is rubbish. It is because that person managing does not know that he has to target, in this case, 80. He will target 50, 60, 70. And if he targets lower than what is natural for that person, obviously the person is not going to breathe because for him he's being hyperventilated. And he will try not to breathe so he can raise the PCO2 automatically to what the baseline is. Okay. So there is no such thing as failure to wean. It is failure of the intensivist to correctly manage and wean.
So you have to treat underlying disease, underlying problem, and after that, as sir rightly said, in these patients, never look at PO2 and PCO2. If patient is conscious, even at saturation of 40 and room air 21%, absolutely fine. And even if the PCO2 is 100, but pH is 7.35 to 7.4, that is the value. So if you target pH and the mental status or awakeness, it's very easy to take these patients off once you, of course, treat the underlying etiology. So moving on to the second ABG, the next ABG are quite simple. Someone's mic is really making a lot of noise, so just mute yourself. ABG2, a 49-year-old man, known COPD, already a known COPD, is operated for pseudocyst of pancreas 1 week back. His abdominal drain is in C2. Now he's febrile and hypotensive. List all the acid-base abnormalities in this report and list 3 possible causes for low bicarbonate in this patient. Now, what are the things in this patient's history? Number 1, sir, I don't have control. You will have to do next. Okay. So, patient is a known COPD. He's operated for pseudocyst of pancreas 1 week back. Now he's febrile and hypotensive. Okay, this is from the history. I mean, if you know the causes, you know, if there is a pseudocyst and the pancreatic drain which is there, we always think of what kind of metabolic disorder? Anyone? If you have pseudocyst of pancreas. Hello?
Nagma.
Excellent. Nagma with?
Hypokalemia.
Yeah, but excellent. Most importantly, it's Nagma. So very good. So I would pick up Nagma here. I already know that patient is a COPD. Patient is febrile and hypotensive. Plus, it is already asking you list 3 possible causes of low bicarbonate, means you're looking at some metabolic acidosis. Now, since the question here is list all the acid-base abnormalities, you are in the exam, you're not expected to comment on oxygenation or ventilatory status. Acid-base status means straightforward acid-base status. So you should not waste time in the exam solving the oxygenation and ventilation. For practice, if you're doing this ABG at your bedside, it's fine. But from exam point of view, you don't want to do that. Sir, next. Okay. So when you look at the pH, because acid-base disorders, you know 6.92. So it's acidemia, very, very low pH. What is causing acidosis? Sir, previous one. Sir, previous one. You're going fast. Okay. pH is acidemia. PCO2 is normal, so that is not causing the acidosis at this moment. Bicarbonate is low. It's just 8. That means it's primary metabolic acidosis, which is causing low pH at this stage. Now, what do you do once you get a metabolic acidosis? You do 2 things. Number 1, you look at what is the compensation to see if there is any respiratory problem. And number 2, you look at the anion gap. So let's take first step, compensation. If the bicarbonate is dropped from 24 to 8, PCO2 also should drop equivalently from 40. I'm not even doing any calculations because PCO2 has not dropped at all. That means there is already a respiratory acidosis. Understood? Even if I say it is dropped by 14, 40 minus 14 should be around 26, but it is 40. I mean, if there is no change at all, there is already a second primary disorder. So this patient has a respiratory acidosis. So you got here primary respiratory acidosis and metabolic acidosis. The second step of metabolic acidosis, then you look at anion gap. Anion gap, you know, sodium minus chloride plus bicarbonate, which is 20 here when you calculate. The expected anion gap is, we do not have albumin here, so you just do correction for pH. pH is low, so from 12, you deduct 2. So expected anion gap here is 10. So delta anion gap is also 10 because 20 minus 2. Your actual anion gap is higher than expected. That means patient has got high anion gap metabolic acidosis. When you get a high anion gap metabolic acidosis, you go to the next step, which we call it as a corrected bicarbonate to look for any hidden disorder. Okay. Now, how do you calculate? You take delta anion gap, which we already calculated here. To that, you add actual bicarbonate from the ABG, which is 8. So delta anion gap is 10 plus actual bicarbonate from ABG is 8, which is equal to 18. Now, bicarbonate should be 24, but here it is 18. That means there is a hidden another acidosis which is going on. Now, if you already got HAGMA, another hidden acidosis becomes normal anion gap metabolic acidosis. So now you have got a final answer. When we say list all the acid-base abnormalities, you have 3 disorders, 3 acidosis. primary high anion gap metabolic acidosis plus normal anion gap metabolic acidosis plus respiratory acidosis. So I think I have seen the answer. Many of you have got this answer. But if anyone had not got this answer, have you understood it? Or anyone has any doubt? Sir, बहुत fast गया. Back. Next, sir.
Ma'am,
Yes.
regarding that PCU, if PCU is normal, then how it is respiratory acidosis?
You tell me, for metabolic acidosis, bicarbonate 8, what is expected PCO2? It should drop from 40.
It should drop.
It is not
Yes.
dropped. So even if I say it should drop here,
Mm.
basically it's 1 to 1.5 times. Sir, previous slide. It is 1
So
to 1.
I got it, ma'am. Let me.
Ah.
If it is like start, it will be like 50, 60, then it came to normal. So it is like already dropped from higher.
No. It has not dropped only. 40 hai, 40 say it should have dropped to at least 26.
Okay.
You tell me what is the expected bicarbonate in this patient? Forget PCO2. I mean, forget the what is expected PCO2 in this patient if bicarbonate is 8? Can you tell me? You must have solved in your example.
Yes. Expected PCO2 is like.
There
I'm
has to
not
be range. It's 1 to 1.5.
1 to 1.5.
So kitna? 24 to?
Between 16 and 24.
Between 16 to 24. Yes. Baseline. So it is from 24, bicarbonate is dropped to 8. That means it is dropped by 14. So your PCO2 should drop by 14 to 21 from 40. So expected PCO2 is 16 to 24 for this bicarbonate. So if it is more than 24, when the PCO2 is higher than expected, you call it as acidosis.
Okay, got it. Now got it.
Patient has got very fact is it has not moved. It itself tells you that there is a respiratory acidosis.
Yes. Okay.
Compensation is the same direction. That's why.
Yes. Compensation is always.
It is always compensation is the same direction.
Yes, and it has not moved. So there is. It itself tells you that there is. Okay.
Yes.
Okay. Got it now.
Great. Anyone any doubt? This was that way pretty straightforward. But if anyone is not understood, please ask. Otherwise, we'll go to the next ABG. I mean, next question. Sir, next slide. Next slide, sir. Next slide. Okay, sir, previous slide. I'm so sorry you don't. Okay, list 3 possible causes for low bicarbonate in this patient, and that would be number 1, lactic acidosis from hypotension. Why? Because the patient has normal potassium. And how much is the drop? Sir, can you go to the previous slide? I'm sorry. What was I explaining? Okay, we have not given the lactates here, but you should suspect lactic acidosis. If the lactates were given here and the drop was exactly the same as drop in bicarbonate, it would straight away go into the favor of lactic acidosis. But the another hint is the potassium is normal, because in acidosis, your potassium will change. So if you get a metabolic acidosis with normal potassium, with the background history of hypotension in this patient, you should suspect lactic acidosis. So next slide. Second one is pancreatic fistula. We already picked up in the beginning from the slide. And in our disorder of acid-base abnormalities, we did find normal anion gap metabolic acidosis. So another one is NAGMA. And third one is excessive saline resuscitation, which will also cause NAGMA. And that can cause normal anion gap metabolic acidosis. So these are the 3 possible causes of low bicarbonate in this patient. Okay. So next. Yes, there is hypertension. So next slide. Okay, ABG 3. A 50-year-old man having ischemic heart disease is admitted with acute pulmonary edema. On 4th day, he's clinically dry, chest X-ray is clear, but now he's becoming drowsy. So new problem is started, drowsy. This is his ABG. You have to comment on acid-base status. What is the most likely reason of his low PO2 and what is the drug of choice? Now, next. Sir, next slide. Hello. Sir, can you hear me? All of you can hear me?
Yes.
Yes, ma'am, we can hear you.
I'll just try to contact sir because the control is not.
Sorry, there was a problem. Am I audible now?
Yes,
Yeah,
sir.
because I was
Yes,
locked
sir.
out. I was locked out of the screen, and so Meeta is now sharing her screen.
Okay, sir, even I couldn't do anything. मेरे यहाँ से कुछ control नहीं हो रहा था. So just something wrong with the this thing. Anyways, so we are on this third ABG. We already know this patient has a ischemic heart disease. The history has been given, and patient is admitted with acute pulmonary edema. What do you think? How do you treat acute pulmonary edema? How do you treat acute pulmonary edema?
Diuretics.
Diuretics. Okay, so patient has improved. So patient has received diuretics and now patient is dry. Okay. So if patient has received diuretics, what would you expect in the ABG?
Alkalosis, metabolic.
Exactly. Metabolic alkalosis. So that's what you are expecting from the ABG. So now when the three questions are there, comment on the acid-base status. Again, you are not going to comment on initially oxygenation or ventilation. You're just going to comment on acid-base status. Then when second question is most likely reason for is low PO2, here you have to calculate the A grade or you look at the oxygenation and we'll come to the drug of choice later. So now let's look at the acid-base status. pH is high, so it is alkalemia. What is causing alkalosis? PCO2 is high, that causes respiratory acidosis. So this is not the primary reason, but definitely bicarbonate is high. So the reason is metabolic alkalosis. Now, what is expected PCO2 in this patient? 24, bicarbonate has increased by 20. That's why it has become 44. What is the compensation of bicarbonate PCO2 in metabolic alkalosis? How many times?
0.5 to 1.
0.5 to 1. So if it is increased by 20, you expect change by 10 to 20. So 0.5 becomes 20 half and 10 to 20. So you will expect PCO2 to be 50 to 60. Here it is 50, so it is compensated. That means this patient has pure metabolic alkalosis. Okay, there is no respiratory acidosis. It's primary metabolic alkalosis because it is well compensated. Any confusion till now? So the only acid-base abnormality here is metabolic alkalosis. Okay, and it's supporting potassium is 3.2. So basically, as we rightly picked up in the beginning, you said diuretic causing volume depletion and contraction alkalosis, and you're also causing loss of potassium, that is 3.2. So your first question's answer is primary metabolic alkalosis. Second is, what is the most likely cause of is low PO2. PO2 is 72. So we have to comment on the oxygenation status. Absolute value is 72, which is low, but it is not very low. So it's mild hypoxemia. On FI2 of 21, so say 20, you expect the PO2 to be around 100. Here it is low, so you have to basically calculate AA gradient. So when you calculate the AA gradient, it comes to 15, which is normal AA gradient. That means there is no underlying lung pathology. It is just pure hypoventilation. Okay, there is no underlying lung pathology. So this was the answer to your second question. Now the third question, how will you treat this patient? This patient is, why do you think this patient is becoming drowsy? Why do you think this patient is becoming drowsy? Am I audible?
Low chloride.
Yes.
Yes.
Due to increased BP.
Hypotension and hypokalemia.
No.
Due to
Does
hypoventilation.
potassium cause?
Hypoventilation.
Exactly. Who said that hypoventilation?
Renuka ma'am.
Yes, patient is
Yeah, but-
hypoventilating. And why do you think patient is hypoventilating?
Hypoventilation, it is due to
For compensation.
For compensation of
three
metabolic
of them-
alkalosis.
alkalosis.
2-3 of them said hypokalemia as a cause of altered
No,
sensory.
that's, I was just saying, does potassium affect the central nervous system or it affects
No,
the
ma'am.
muscles? Exactly.
No,
So
no.
that cannot be the reason. Hypokalemia can never be the reason
Cannot
of
be the reason.
drowsiness. Yes. Yes. So patient's PCO2 is rising. That is the reason patient is becoming drowsy. And that basically his PCO2 is rising because body is trying to compensate for alkalosis. So what do you have to do now? You have to treat. How will
Potassium
you treat it?
Beta blocker.
No.
How will you treat? How will this patient's drowsiness will go? What is the primary reason of this?
NIV.
Alkalos.
Alkalosis? Who said that?
Alkalosis.
Who said
Jai
that?
Kishan.
Jai Kishan. So you have to basically treat alkalosis because if you treat the alkalosis, PCO2 will normalize and patient will be normal. So how do you treat now alkalosis in this patient?
Stop diuretics.
Diuretics.
So by stopping diuretics,
Potassium.
bicarb will normalize.
No.
Second thing, if you stop the
Potassium sparing diuretics.
Carbonic anhydrase inhibitors.
if you give carbonic anhydrase inhibitors, what will happen to potassium?
It will again fall down.
It will again fall down.
Fall
Dimox
down
causes
again.
hypokalemia. So you don't want potassium to drop further.
Potassium sparing diuretics.
Excellent. Will you give fluid to this patient? Because the treatment of metabolic
No.
alkalosis is fluids and potassium
Fluids.
correction.
Potassium.
So will you give fluids?
No.
No,
ma'am.
ischemic heart
No.
disease. Pulmonary
Yes.
edema history.
Yes. Basically, patient came to you with pulmonary edema. So you don't want to give fluids. Otherwise, if this was not a pulmonary edema, we would definitely give fluids and correct potassium. So here, either you continue giving the patient small dose diuretic may require in this patient because this patient has a pulmonary edema and with underlying ischemic heart disease. So, or that means you overcorrected this patient overzealously, but you cannot give fluids to this patient. So either you can give potassium, little fluid, oral, not IV. But the best thing is to give potassium sparing diuretic because that will increase the potassium and have mild diuresis in this patient. Yeah, so I think many of you got this correct in your worksheet answers. Anyone has any doubt?
So our goal also is like giving mild diuretics. That's why we are giving potassium sparing
Potassium,
diuretics.
yes, potassium.
And
because
also,
because in the history you saw a patient is already clinically significantly dry, X-ray is cleared. Now, if you go further for the treatment, basically you have to take care of his underlying ischemic heart disease. Because of that, patient is so further investigation will go on echo, angiography, whether there's an acute MR or if there's an vessel which needs to be angioplasty, so and so. But as of now, because patient came into pulmonary edema, you will give potassium sparing diuretics.
and ma'am, do we need to calculate that expected A gradient, or it's like we have to that?
What expected? We calculated A gradient. No, it came normal, 15. So that means there was no underlying lung pathology now. Patients, as it is, X-ray was clear and patient was dry. So pulmonary edema is gone. Patient's PCO2 is high. PO2 is low only because of hypoventilation. And why was patient hypoventilating? For compensation of metabolic alkalosis.
Okay.
Okay. Right. So let's go to the last ABG, which is quite simple, simplest of the all 4 ABGs. There is no history given, just an ABG of a 53-year-old man from ICU. List two possible diagnoses for this abnormal ABG. This is almost like a PCCM question. So when such question is asked, you have to quickly work up the complete ABG to get to the final abnormality, because unless you diagnose what is the abnormality, you'll not be able to say what are the possible causes. So let's quickly look. Oxygenation is normal, so I'm not going to waste time on that. Ventilated status, patient is hyperventilating. So we just got up till now that this patient is hyperventilating, and we need to find out why this patient is hyperventilating. So let's go to the acid-base status. 1 second. I just got stuck. The presentation got stuck. Okay, acid-base status. What is the pH? It's normal, but it's low normal, 7.35, because we know the normal value is 7.35 to 7.45. This is low normal. So that means if at all we are looking at any abnormality, we are looking at some acidemic abnormalities, something which is causing pH to lower side. PCO2 is respiratory alkalosis, so that cannot cause a low normal pH. So then we have to look at the bicarbonate. Bicarbonate has metabolic acidosis because it is low. Bicarbonate is 12. So the next step would be expected PCO2. Bicarbonate from 24, it has dropped to 12. That means the drop is by 12. So the drop in PCO2 would be from how much? I've already written 22 to 28, and it is falling in that range. So this patient has got metabolic acidosis. The next step, the moment you get metabolic acidosis, you have to calculate anion gap. Anion gap is 24. Expected anion, yes, expected here is 12 because pH is normal. So there is no correction and we do not have any albumin. So it's HAGMA, high anion gap metabolic acidosis. What is the next step?
Corrected bicarb.
What is the corrected bicarb? What is
Delta anion gap plus bicarb.
So it is delta anion gap here is 12. Correct? The difference between expected and actual is 24, expected is 12. So what will be the delta anion gap?
24. 12 plus
12. 12.
yeah.
So that 12, if you add to bicarbonate, it is
that is 24.
So it's
so
pure
purely
high.
HAGMA.
Exactly.
Pure HAGMA.
Correct, Sudhir. It is pure
Yes,
HAGMA. There is no hidden disorder. Okay. Any other abnormality in this report?
Hypokalemia.
Exactly. So now you got a pattern which is high in anion gap metabolic
metabolic
So
acidosis
basically
with
you got
hypokalemia.
so basically you got a pattern of metabolic acidosis with hypokalemia. Anyone remembers? Anyone who wants to elaborate the causes of metabolic acidosis with high anion gap? What are the causes of this? Is a data pattern. Metabolic acidosis with anion, metabolic acidosis with hypokalemia. Just that much.
Hello.
No one?
Lower GI issues.
Lower GI issues like diarrhea.
RTA type 1.
RTA type 1 and type 2.
And type 2.
Okay. What else?
Nita, you're saying with
Diabetic
nagma?
No,
Or
just saying
HAGMA?
overall causes of
Okay.
metabolic acidosis with hypokalemia. So you said lower GI causes, renal tubular acidosis type 1 and 2. What else?
Drugs.
Hypokalemia.
Pardon?
DKA with hypokalemia.
Can't
Decay
understand.
in a longer.
No one?
Long-standing.
Infusion.
Long-standing decay.
Decompensated decay, okay? Decompensated decay or during the treatment phase of decay. What else? What drug someone said? What drugs?
Medications.
What medication? Amphotericin B toxicity.
Amphotericin B toxicity.
Right? What else?
Ethanol, methanol toxicity.
Ethanol, methanol does
No,
not
no.
cause hypokalemia.
Oh,
Adrenaline.
hypokalemia, it doesn't.
Adrenaline.
Adrenaline infusion.
Adrenaline infusion in shock.
Infusion.
Okay.
Shock.
What else?
Beta
One-
agonist.
Correct. Beta agonist. So now out of these three, out of all these 7 causes you said, now you have to deduct what are the causes of high anion gap metabolic acidosis with hypokalemia. So let us rule out. Number 1, lower GI causes. Can it be caused in this patient?
No.
Yeah. Why? Because it causes
No.
a normal anion gap. Correct.
Normal anion
Can
gap.
RTA be the reason in this?
No.
No.
Again, Nagma. Can amphotericin B toxicity be the reason?
No. No.
Yeah, because that also causes
Fine.
normal anion gap metabolic
Normal
acidosis.
anion gap metabolic
Can
acidosis.
treatment phase of decay be a reason?
Maybe.
Treatment of decay.
Yes.
Maybe.
So when you treat the decay, how do you treat the decay?
With insulin, it can
Within
cause
the
hypokalemia.
Fluids.
Fluids.
Yes.
Fluids.
Fluids.
So fluids will cause what anion gap?
Hyperchlorine.
Yeah. So that is also off. So you are left with adrenaline infusion in shock because shock will cause high anion gap and
Shock
even
will cause anion.
adrenaline causes high anion gap. Second one is beta agonist toxicity like theophylline and third or salbutamol. Third one becomes decompensated stage of
Decompensation decay.
Correct. So in final, you have to write down only these 3 because the question was 3 possible, any 2. The question was for this abnormal ABG, and you must remember that it is not just the data pattern of metabolic acidosis with hypokalemia. It is hypokalemia with which kind of a metabolic acidosis that you have to look at. So it's a high anion gap metabolic acidosis. And based on that, any of these 2 you write, you will get 25 marks. So these are the 3 causes of hypokalemia with high anion gap metabolic acidosis. If this was a normal anion gap metabolic acidosis, you will not write this. You will write the other ones like a lower GI causes, where you will write diarrhea, fistula, etc., renal tubular acidosis, essentially the first one. Okay. So have you understood? These are the type of questions you expect to get in the exam. You are done with all the 4 ABGs. Now you can have any doubts or questions, you can tell.
Ma'am, this is Vinod here.
Yes, Vinod.
Yeah, Vinod.
Ma'am, for this pH correction, we are considering 7.35 as acidemia. So should
It's not
we
acidemia.
calculate the
Yeah, what
Okay.
I said, it's normal, but it's low normal.
Okay.
If this was
So while
7.45, I
calculating
would
the
say,
expected anion gap,
huh?
so should we do a pH correction for this or no?
No, because it's between 7.35 to 7.45.
Okay. Okay.
So if we take it as just 12, you don't deduct any. That's why we didn't deduct. See, we have
Yes,
not
ma'am.
deducted. Yeah.
Yes.
Good.
Thank you.
Anyone, any other doubt in any other ABG? Otherwise, we are done with the ABG.
Those
session.
who are finding it little difficult, want to revise, please do the ABG, which is the recorded ABG lecture, which is there, and revise it, make notes so that we can move on. There is so much more to learn besides ABG. This is just one
this
component.
is now this is the last session as of now of ABG because we have to cover other. Then at last again we'll start. Once we finish all, I'll start sharing again the ABGs. But for revision, as sir rightly said, and many of you have subscribed, because that session you can pause, you can listen to it again and again, you can clear your doubts.
Make
If you have any
notes,
other doubts,
compensations,
yes,
all that
is
you can
important.
understand.
And I think most important is you must practice your ABGs at the bedside in the ICU by this method. Then only you'll be more confident of solving the ABGs.
And if there's a difficult one, you can always share it in the group and the others can also learn from it. If there is something that is unique, that is there,
Yes.
or you're stuck somewhere and you want a second opinion, don't expect Dr. Meeta and me to be solving everyone. But you have a team of friends.
Yeah,
and
you
they
have
will
so
solve
many
it.
other people. So as he's absolutely right. If you find something interesting, maybe just start with ABG because we just finished 2 worksheets on ABG. You find an interesting ABG which you have already solved, or if you're stuck in any either ways, put it on the group, let people solve it. That will be a practice for everyone.